Good evening, everyone. Today we are going to be dealing with interventricular conduction defects. But before we start, I would like to tell you to subscribe to my channel. If you have not, if you are watching this video for the first time on my channel, please subscribe and hit the notification button so that anytime I drop a new video, you are among the first people to receive the notification, because I always put hot topics. So today we're starting with this one. Interventricular conduction defects. These are conduction abnormalities that happen within the ventricles. So they have many types. We have like bundle branch blocks, which includes LBBB, left bundle branch block, and now right bundle branch block. And then in LBB, others can be fascicular blocks. Fascicular blocks in LBB, because left bundle branch is divided into left anterior fascicle and then left posterior fascicle. So if one of those ones is blocked, we call it a fascicular block, and it can be left anterior fascicular block or left posterior fascicular block. Those two. And then from bundle branch block we are going to go to non-specific non-specific intraventricular conduction defect. Non-specific intraventricular conduction defects. This one can be written as IVCD. That one, non-specific intraventricular conduction defects. So from here, we are going to look at one by one. In bundle branch blocks, we have left bundle branch and then right bundle branch. If I can draw the conduction system here real quick, just to remind you, we have the SA node here, and then we have the AV node here, internodal pathway of fibers to the Bachmann's bundle. This is the AV node. It gives the bundle of His. Then this one will divide into the right bundle branch, and then it will also give to a left bundle branch. But left bundle branch will give to two branches, which is, I named this one already, SA node, this one AV node, bundle of His, and then we have left bundle branch, and then the right bundle branch. That one already named. And then we have this one as, depending on where you read it from, left anterior fascicle, and then this one is left posterior fascicle. So any of these, any block can happen anywhere. We are looking at interventricular. So this ventricle starts from there going downwards. Any block happening at this time, but specifically any block that happen inferiorly at the end of or at the bifurcation of bundle of His. So the one thing we are going to do first is going to be, we look at right bundle branch block. I can write it in full. Right bundle branch block. We have already finished these things, like what we expect in a normal ECG and what will happen. So just real quick again, for bundle branch block, for bundle branch blocks, we are going to, for example, RBBB specifically, we shall look for it in V1, read V1, and V6, but specifically in V1. So what do we expect in normal? And again, we are checking the QRS. Normal QRS in V1. What do we expect? We expect a normal Q, P wave, and we expect a small r and a deep S, and then P wave. This is what we expect. Again, if you go back to what we finished, the depolarization of the ventricles, we finished this one, but just as a reminder, we are drawing some part of our myocardium here, and this is what we did when we had that time. We said first one is septal depolarization, 2 is the free wall, this is 2, and then 3 is a basal parts. Which are basal parts? They are these ones. And what was the net of free wall depolarization? Was going this side. So we said the septum depolarized from left to right. So this R, since it's number 1, is for septal depolarization. But since it is going the same direction with 2, so we get the sum of septal and free wall depolarization, and then we subtract whatever is going on the left, and whatever is remaining, it will go on the left. And indeed V1, which is situated at this point, and V6, which is situated at this point, these are their positive poles. This septal depolarization will be reflected as R. And then the rest, 2 going to the right, 2 going to the left. Left is thicker than the right. Net will be going to the left, and it will be recorded as R. Why? It is going away from the positive pole of lead 1, lead V1. And then what do we expect in V6? V6, we expect a P, and since this septal depolarization is going away from the positive pole of V6, it is going to be recorded as a small q, and then the net, since it is going towards the positive pole of V6, it will be recorded as a tall r. In some point, the basal parts can be seen or may not be seen. So this time I'm assuming they are not seen. So this is P and then T. This is R. Huh? So this is in V6. So what happens in left bundle branch? For example, the normal depolarization of the septum is from left to right. If right bundle branch is blocked, you block right bundle branch, what will happen to R wave in V1? Will it change? So I'm writing in RBBB. That's what we are seeing for RBBB. So in RBBB, what do we expect? We expect phase 1 of ventricular depolarization, that is septal depolarization, to remain unchanged because it is depolarized by the left bundle branch. So we get the normal P and then still a small r. Now what happens to 2? In 2, since this one is blocked, in 2, this one is blocked. So, and this one is going towards the other side in the normal conduction system. Normal conduction system is capable of faster conduction. And once one is blocked, faster conduction is blocked at that side, towards that side. So whatever, it has to depolarize, but through other means. And which other means? They are non-specialized conduction tissue. Those are myocardium. They can conduct, but very slow compared to if it passed through the normal conduction system, that is bundle branches and Purkinje fibers. So these are Purkinje fibers again. So R is undisturbed. What happens to in V6? Still Q is undisturbed. It is still there. Now for stage 2, Since this one is working, this one is not working, this one will be slow through the non-specialized conduction tissue, and this one will be fast towards the left side, the left ventricle, through the specialized conduction tissue. So we expect this side, the left, to be depolarized fast, and it is, since it is going away from V1, we expect a negative wave, and it is big, that is S, and here it will be recorded as R. Yeah. And now the next one, it is when it will move now. After depolarizing this side, it will come trying to depolarize the right side. And now the right side being depolarized, it will be coming towards the positive pole of V1. And since it is through non-specialized conduction tissue, it will take some time. It is slow conduction. So slow conduction is indicated as a white wave. Yeah, very wide. And now the next can be T wave inversions, OST depression, T wave inversions, but here I can leave it as normal. That is for RBBB. And now for V1. Now in V6, this is what we expect. I expect a deep and wide S wave. And yeah, but in most cases, this T wave will be inverted in RBBB, in V1 and V2. It will be inverted. So this is the morphology we expect in RBBB. You can check other leads like lead 1 and AVL. They will still show a slat or a wide S wave. They will have R wave and then something like that, S wave. So this is R, S, R prime pattern, rabbit ear pattern in V1. So this is V1 again, this is in V6. So this is the pattern in right bundle branch block. What have we said? We said if this one is not working in RBBB, so I'm drawing a small myocardium here. Small myocardium, I'm drawing ta. This is small myocardium. This is what we expect. We expect this one, septal depolarization, to be number 1 as usual. But what will happen next? It will be this side as number 2. Okay. And then this one will happen as the number 3. In the usual state, they happen at the same time. But in the RBBB, this one is depolarized later as 3. So expect 1 as R, 2 going to LV, S, and 3 going to RV as R prime. That is RBBB. Now features of RBBB, apart from this one, we have so we can write as ECG features of right bundle branch block. What do we expect? We expect white QRS complexes. Complexes, we expect it. Normal QRS is less than 120. So in RBBB, if it's complete, duration is above 120 milliseconds. Yeah. If it's incomplete RBBB, it will be 110 to 120 milliseconds. This is incomplete. So it can be, bundle branches can be incomplete or complete. Complete when the duration of the complete QRS duration is above 120, and then incomplete when it's less than 120 but it's above 110. That is one. we expect this morphology, rabbit ear morphology of QRS in V1. For example, complex named as RSR prime. We need it. We have seen it there, how it comes. So this one is needed. Another one we need right axis deviation. Right axis deviation should be there. And then another one is from right axis deviation, another one should be T or ST changes in V1 and V2. Right bundle branch can cause that. The what are STT changes? That is T wave, inversions in these reads. Yes, that one. So causes of RBBB. Causes of right bundle branch block. Causes can be a normal variant. Normal variant. Some people can have RSR prime in V1. Not because they have the right bundle branch, but it is normal. Nothing wrong with it. So right bundle branch is not always pathologic. But where it can come from, where it's pathologic, is right ventricular hypertrophy. We finished this. And then we can have pulmonary embolism. And then ischemia or myocardial infarction, or what else? Age, sclerosed. It comes with time. Yeah, so this is a right bundle branch block. So next time is to show you ECG with right bundle branch block.